Good afternoon. Good afternoon, everybody, and good morning and good evening to those who are joining from other time zones. It is my great pleasure to welcome you to this interactive dialogue. Cancer patients are the most obvious victims of the superbug crisis. Why we need to talk about the impact of antimicrobial resistance on cancer care outcomes. It's organized by the UICC and the Welcome Trust as part of London Global Cancer Week. My name is Shonali Johnson, and I am the head of the Knowledge, Advocacy and Policy Unit at the Union for International Cancer Control, and I will be moderating today's dialogue. We're going to start with a welcome message from Dame Callie Palmer, the National Cancer Director from NHS England.
National Cancer Director for NHS England and Improvement. It's my great pleasure to welcome you to London Global Cancer Week 2020. The aim of London Global Cancer Week is to really focus on improving survival in low to middle income countries so that we can make a difference to people experiencing cancer and the effects of cancer around the world, and together help to improve survival. I'm delighted that the UK has played a leading role in convening London Global Cancer Week this year. There are going to be 24 virtual events running from Sunday the 15th through to Friday the 20th of November, really focusing on action and practical steps to help improve support for people around the world. Thank you for joining. We have a number of organisations contributing, including WHO and the Commonwealth. It's a fantastic collaboration of people and teams to help us all make a difference. And I really look forward to hearing the outcomes of the week. And I'm sure it'll be inspiring, moving, and a really important week for all of us. Thank you.
Wonderful. Right, well, let's get cracking then. So the topic for today's session, cancer and AMR, is very fitting, as this week is also the World Antimicrobial Awareness Week. Antimicrobial resistance presents one of the biggest threats to modern medicine. For those of you who are less familiar with AMR happens when microorganisms such as bacteria, fungi, viruses, and parasites no longer respond to medicines that are meant to kill or limit their growth. And as a result, medicines, including antibiotics, become ineffective and infections persist in the body. Now, for cancer patients, this is very, very worrying, as people with cancer are more susceptible to infections due to the lowering of their immune system. As many as 1 in 5 cancer patients undergoing treatment are hospitalized due to infection, particularly pneumonia and sepsis. And of course, antibiotics are a key part of cancer care for cancer surgery and infection prevention. So as the problem of drug-resistant bacteria grows, the progress we have made in cancer treatment and care is threatened. So AMR is a topic of great importance to the cancer community, and this is why we are organizing this session as part of London Global Cancer Week. And we're going to hear from the experts in this area talking about various aspects of AMR and the steps we can take to address this pressing global health issue, because there are steps that we can take and we must take now. We have a fantastic panel lined up for you today over the next 1.5 hours. So in order to maximize our time, I would just ask our speakers to kindly stick to their time limit. And I would also kindly ask our colleagues on the call, the participants on this call, to please mute their microphones. And you are very welcome to use the chat box to interact with the speakers and to ask any questions. So now it is my great pleasure to introduce our first speaker, Dr. Abdul Ghaffar. Dr. Ghaffar is a consultant and adjunct professor in infectious diseases at the Apollo Hospitals, Chennai, in India. He is a technical advisory committee member for national antibiotic policy of the Indian Ministry of Health. He is the primary author and coordinator of the Chennai Declaration, a document and initiative by medical societies in India to tackle the challenge of antimicrobial resistance from an Indian perspective. And he has received the Indian Medical Association Oration Award for his contribution towards tackling antibiotics resistance efforts. Dr. Ghaffar's talk is entitled, "The Threat of AMR, a Global Crisis." Dr. Ghaffar, you have the floor. Thank you very much.
Good afternoon. Thanks, Sonali. Infections are the commonest cause of death in cancer patients. Cancer patients are the most vulnerable to the challenge of antimicrobial resistance. AMR is considered to be a silent pandemic. But in cancer patients, AMR manifests as lightning. A febrile neutropenic who is sitting and smiling may end up in intensive care unit in an hour. India has one of the highest AMR rates in the world. With more than 1 billion population, the socio-economic disparity and diverse healthcare system, India has a perfect recipe for the AMR crisis. The more the resistant the bacterial infection is, the higher the death rate in cancer patients. So how did the cancer patients in India survive the intensive chemotherapy regimes during the challenging years of AMR crisis? How did the Indian oncologists continue to provide chemotherapy services with good results? Infectious disease physicians and microbiologists are always well versed with the challenge of AMR. Over the last several decades, we were trying to convince the medical fraternity on the importance of rational antibiotic usage. Well, AMR is our specialized area of academic and clinical interest. Oncologists in India have made a significant role in tackling the socio-political challenge of AMR. Oncologists are one group of doctors who experience the AMR challenge in its worst form in their everyday practice. As an infection specialist working in an oncology center in the country, and as the coordinator of Chennai Declaration Initiative on AMR, I believe Indian oncologists deserve a loud applause for the support they have shown for the implementation of antibiotic stewardship and infection control policies in oncology centers in India. In 2012, the medical societies in India came together to launch an initiative to convince the medical community and the policymakers on the need to tackle the challenge of AMR in India. The initiative is now known as the Chennai Declaration. The journal that published the Chennai Declaration document is Indian Journal of Cancer. Chennai Declaration Initiative is one of the most significant efforts in India to tackle the socio-political challenge of AMR. Chennai Declaration played its cardinal role in bringing out the rule in regulating over-the-counter sale of antibiotics and the ban on the use of colistin as a growth promoter in animal farming. Across the world, oncohematologists played a significant role in tackling AMR efforts. Professor Dame Sally Davis, one of the admirals in the tackling AMR army, is a hematologist. Sincere and coordinated efforts of activists, non-governmental organizations, governmental agencies, World Health Organization, and United Nations played a significant role in convincing the world that AMR is one of the biggest challenges the global healthcare system ever faced. Unfortunately, the global momentum in tackling the AMR challenge is now very slow. Most countries haven't yet implemented their national AMR action plan. The world is still suffering from AMR crisis, even during the COVID era. AMR is a complex challenge similar to global warming and poverty. Coordination, persistence, and perseverance are the keys to tame complex challenges. We should learn from our past successes and failures. It's high time the World Health Organization should relaunch the global AMR action plan. AMR has made a significant negative impact on cancer care at the global level. So far, we stood united against the superbug menace. We should continue to fortify our defense against the enemy. If we stand united, we can tame superbugs. If we do not, the present and future generation will succumb to the untreatable bacterial infection. Thank you.
Thank you very much, Dr. Gafour, for your very passionate talk. And you mentioned some really key points, particularly that it may be seen as a silent pandemic, but actually, it really is a disaster for many cancer patients and threatening their treatment. You also talk about the implementation of the global action plan on AMR and how that needs to be implemented at national level. So thank you for those points, and we look forward to getting into the policy actions later on in this interactive dialogue. It is now my great honor to introduce our next speaker, Dame Sally Davis, the UK Special Envoy on Antimicrobial Resistance. Dame Sally was the Chief Medical Officer for England and Senior Medical Advisor to the UK government from 2011 to 2019. She has become a leading figure in global health, including serving as a member of the World Health Organization's Executive Board in 2014 to 2016 and as co-convener for the United Nations Interagency Coordination Group on Antimicrobial Resistance, reporting in 2019. And this year, we extend our congratulations to Dame Sally, because in the New Year's honors, she became the second woman, the first outside the royal family, to be appointed to the Dame Grand Cross of the Order of the Bath for services to public health and research. Dame Sally's talk is entitled Handle with Care, How to Move Towards Better Policy and Better Outcomes. Dame Sally, welcome. You have the floor. Thank you.
Thank you very much, Sonali. So, hello everyone. It's a great pleasure for me to be with you talking about issues that are close to my heart because they affect all of us, every one of us. And this week marks both Global Cancer Week and World Antimicrobial Awareness Week. So, great week to recognize the issues we face together, but even better to start to act together. I think we've probably all had personal experience of cancer. I cared for my mother as she died of cancer. I'm a hematologist, so I looked after many patients, as Abdul Gafour said, with leukemia. So I want to congratulate the Union for International Cancer Control and the Wellcome Trust for organizing this inspiring conference and bringing us together, knowing that collaboration is vital for our global health, but also for bringing a patient face to AMR. We really need the patients demanding of their health systems and governments action. It's interesting, isn't it, how 2020 has brought the world closer because of Zoom and a shared health threat. But it makes it all the more imperative that we work together because we're only safe when everyone's safe. And 2020 is a critical point in time. The United Nations Secretary General is clear that recovery from COVID-19 has to work for everyone. We would support that. And that's why tackling cancer and AMR is integral if we're going to deliver the SDGs, because both drive poverty, but both can be mitigated by strong, resilient health systems. Both AMR and cancer are tragic, with impact on millions of people and their families across the world, linked in ways that aren't really apparent to most of the public. Because we know that antimicrobial treatments, antibiotics, antifungals, antivirals are the foundation of modern medical care, enabling our healthcare workers to treat common infections, previously life-threatening infections such as TB and malaria, and also secondary infections for COVID-19 patients or those with cancer. And their widespread use makes modern cancer care possible and safe. For the 1 in 5 patients with cancer undergoing treatment who are hospitalized due to infection, antibiotics and antifungals mean that life, they can be cared for and treated both effectively and safely. But as Sunil said at the beginning, our antimicrobial treatments are becoming less and less effective. It's happening now. So we've got to act or it will only increase. And this matters to patients and their families, as well as the doctors and nurses, because without antibiotics, we risk losing modern medicine. Earlier this year, a UK-based charity, Nesta, surveyed oncologists who shared their own personal concerns that AMR would make chemotherapy unviable. Almost 1/3 of the oncologists surveyed expected this would happen within 5 years. This is why we've got to act today, before it's too late. And the theme of this year's World Antimicrobial Awareness Week is Handle with Care, recognizing the role of stewardship and conservation in preserving our antibiotics and fragile supply chains of them. I believe the most effective way of achieving this is through setting targets. And in the UK, we've got a national action plan setting out how we're going to deliver on all our objectives. And we need to do this to save patients' lives. Across our whole health system, academic, NHS, labs, research centres and community, people up and down our country and across the world are working tirelessly to address the threat of AMR. And 135 countries have now written national action plans, with 50 more currently in development. It gives us a plan and a way forward and a belief that we can do this together. But of course, we've got to develop momentum. We've got to find the funding to support countries to make that progress. It's a scientific issue, AMR, but it's also a behavioral science issue. And the most important thing we have and continue to use evidence to create policy and sustain political momentum. We're not going to be able to do this alone, but for government to act with full force, as I've implied, we need public advocacy. And public advocacy comes from awareness, which is inherently more difficult for issues that are complex, like climate change, or complex and silent, like AMR. We've got to raise awareness across the whole of society about the understanding of AMR, what it is, how it spreads, the severe implications, and how do we get across the rather difficult message that antibiotics are not bad for patients, but they should be used sparingly so they save lives. Together with Public Health England, we've developed school resources to teach about AMR in schools. And if you haven't seen The Mold That Changed the World, a musical by school children funded by the British Society for Antimicrobial Chemotherapy, it's really fantastic and fun and a great way into behavioral change. So I'm asking each and every one of you to play your part. My hope is that by the end of this World Antimicrobial Awareness Week, that more people will know and understand what a threat AMR poses, and that we mustn't allow the bugs to win. Do you know, according to a recent report in the UK, only 19% of adults think AMR is a most serious threat to global health. Even more starkly, less than half of adults in the UK know what they can do to help tackle it. We've got a lot of work to do. We can't stop. We've got to keep spreading the word, and we must care and stem this tide. The UK pioneered the Keep Antibiotics Working campaign, using media to target both patients and prescribers to ensure antibiotics are used and given out when necessary. It's a good start, but we've got to use this behavior now to become the norm, and the awareness to be accompanied by the urgency and passion that everyone here today shares. I hope a lot of the messaging we're seeing now about the importance of hand washing and hygiene will go a long way to helping. And of course, this is more of a challenge in some parts of the world. 2 billion people across the world lack access to basic sanitation, coupled with the fact that cancer deaths disproportionately occur in low and middle income countries. We then see these sad countries facing complex and multifaceted health challenges. As we globally tackle AMR, we do need to tailor our interventions for the localities. We need software that works in different places. We need surveillance that will support people. And I'm so proud that our UK Fleming Fund supports low and middle income countries collect and share their data for action with over 22 countries with grants. And it's really important. We've launched an app to support pharmacists in prescribing with evidence and national guidelines at the core. Such data-driven prescribing practices can ensure that antimicrobials, particularly the ones that are the last line of resort drugs, are reserved to patients where their lives need saving, those patients that depend on them. But we've also got to make use of their limited supplies and ensure access of routine antibiotics for all who need them. We need to handle antibiotics with care. And this summer, the UK became the first country in the world to launch a new system paying companies for antimicrobials based on a health technology assessment of their value to the NHS and society, not on the volumes they're used in. We call this the Netflix model. It's a subscription model, and we hope that it'll bring 2 new antibiotics to the NHS by 2022. But we do know it should empower doctors, nurses, and others to follow appropriate stewardship of new antimicrobials, because there's no incentive for them to use this inappropriately. I really hope other countries can introduce similar innovative mechanisms in their countries, because that would be game-changing for healthcare. In my final comment would be how we've come a long way with our modern healthcare, but we've still got a long, long way to go and too little time to do it. But we can do it working together, from washing hands to spreading the word. We can do it collaborating to protect each other. Thank you.
Thank you so much, Dame Sally. There's just so much in your talk that we really need to consider and think about. And I think it's so important that you talk about the awareness aspect and really bringing it into the health curricula of young people. I think that's a superb action. Young people are being exposed to so much now with COVID-19, even very, very young children, about learning infection control practices at school and so on, and turning this into an opportunity for real health education awareness and starting early, as many of these children will become our future doctors and nurses and health professionals. So that's a wonderful point, including to the other ones you've made. So thank you so much for that. So our next speaker now is Jeremy Knox from the Welcome Trust, a co-organizer of this session, and it's an organization that has been working for a number of years on the topic of antimicrobial resistance. Jeremy Knox leads the Welcome Trust expanding policy and advocacy program on AMR as a key part of the organization's 5-year, £175 million commitment to support the global response to drug-resistant infections through integrated research and policy activities. Jeremy's presentation is on what is the impact of AMR on cancer care and why is it important to raise awareness on this issue, showing us the evidence. Thank you, Jeremy.
Thank you, Sonali, and it's great to be part of this session today. We're very pleased to be involved. I want to talk today about one kind of small fraction of what Welcome is doing and about how we see a kind of really important overlap between the cancer community and what we're doing in the AMR space. I think you'll have gathered by now that everyone on this panel today is really a passionate believer in the fact that AMR is something that we really ought to be tremendously concerned about. Even while global attention is very rightly fixed on COVID, we're still trying to make the case that drug resistance is the next pandemic, slower moving, less visible than COVID for sure, but no less damaging in the long run, and vastly more predictable, entirely predictable, in fact. We spend a lot of our time personally and professionally advocating for governments and the public to take the issue of drug-resistant infections far more seriously, as we've already heard from Abdul and from Sally. I think a core part of this conviction, it really comes from a fear that we have about the impact that this will have on patients. And one of the groups that we see most starkly on the front line here is cancer patients. This is a set of diseases, obviously, that touches millions of lives around the world, and where we've seen really kind of tremendous strides forward in treatments and outcomes. But so much of this treatment paradigm obviously depends on the antibiotics that we have today being effective as a safety net against opportunistic infections. So I think it's no exaggeration to really kind of point to the fact that by taking effective global action to tackle AMR, we can have a vital role in ensuring that we don't end up in a situation where we see a reversal of many years of progress and success in improving cancer outcomes. But I think on the AMR front, we've not been making quite as much progress as we would like in mobilizing action, despite heroic efforts and kind of some very significant breakthroughs. And one of the problems I think we still face is we've not yet been able to mobilize patients and the public behind AMR as consistently or as effectively as they've been mobilized behind issues like cancer over recent decades. Can I have my next slide, please? Thank you. So I want to talk very briefly here about a major piece of communications research that Welcome did last year, which was trying to tap into that point I just mentioned, really understanding how the public engage with the issue of drug resistance and how we as advocates can communicate more effectively and persuasively around it. This was a combination of surveying what people already knew in 7 different countries around the world, or what they thought or what they'd seen in the media about AMR, and then testing different ways of talking about it, the topic, different ways of framing it, if you like, to get them to engage more strongly and consistently. And I realize the colours on this slide may not be great, but what this shows is that really one of the kind of key things we found from this survey work was that in all parts of the world that we looked at, cancer ranked more highly than AMR as an issue of major concern for people. You'll see here that in most countries, or sorry, in a number of countries, certainly US and UK, cancer is the dominant concern when you ask people about their global health threats. I think the only kind of the big caveat to this is this field work was done about 18 months ago. So I think some of the prioritization may have shifted, particularly epidemics and pandemics maybe being kind of more at the forefront of people's minds now. Can I have the next slide, please? So what do we learn from this work about what drives this difference and what we can learn from the cancer space? Firstly, and perhaps obviously intuitively, is the observation that cancer is seen as a much more tangible and salient threat to people. It enjoys significant visibility. It sits very highly in the public consciousness already, in part, of course, down to strong advocacy, but obviously also down to the sheer volume of lived experience out there in the community. In turn, when we looked at the different ways to talk about drug resistance, the most powerful and most resonant messages were those that linked the impact of drug resistance into how it might undermine medical advances in areas that people already really cared about, like cancer. So talking about undermining modern medicine, talking about these sorts of kind of impacts of AMR was far more powerful than taking kind of a language around a war on AMR or kind of the militaristic metaphors that we sometimes instinctively reach for. So it's very clear that drawing this kind of link could hold the key to mobilizing the public behind AMR effectively. But then the next question for us is, well, do we have the evidence we need to make this kind of case to the public and, more importantly, to policymakers? Next slide, please. So to try and get into this further, over the course of this year, we've commissioned some work by RAND Europe to undertake a rapid assessment of the evidence of the impact of AMR in other areas of healthcare. We asked them to look at the published literature for the evidence of the impact of drug resistance across multiple domains, things like patient mortality, intensity of treatment, length of hospital stay, and 10 different types of care, one of them being cancer. And I think it's fair to say we've been slightly surprised with a relatively limited amount of good quality evidence this turned up. For cancer, only 10 studies met the review criteria. 7 of these were empirical, 3 of them were wider reviews. And the overall strength of the evidence was weak to moderate. This was better than many other disease areas we looked at, but still the strongest area, at least in relative terms, was the impact of drug-resistant infections on mortality in cancer patients. Otherwise, the evidence of impact was much weaker than we had anticipated. Next slide, please.
Sorry.
No problem. Thanks. So I don't want to run through all of this in detail for the sake of time, but to pick up a few kind of key conclusions. So the area of strongest evidence, as I said, was in relation to mortality rates. We found some clear evidence, unsurprisingly, that cancer patients may be at greater risk of contracting drug-resistant infections than non-cancer patients, and a higher risk of death where they do. Evidence of increased rates of mortality amongst cancer patients acquiring drug-resistant fungal infections versus those that did not. And then there was at least one study that showed an increase in the risk of recurring episodes of sepsis in cancer patients where they suffer from a drug-resistant infection versus one which is easier to treat, more susceptible to treatment. Next slide, please. So where do we go from here to conclude? So I think we strongly suspect that there is a disconnect here between the volume and the quality of the evidence we found and the reality that we've heard from Abdul and the lived experience that we hear about from other people in the field. This was a common theme in other areas of healthcare that we looked at too. So it's clear there might be some systemic gaps that need filling if we want to kind of make this link between AMR and other areas of healthcare. This is an area where Welcome is keen to develop, so we'll be doing further work in the coming year to understand how we can help provide more definitive answers and close gaps in the evidence base about how drug resistance is or will impact in other areas of healthcare. Ultimately, the goal here, as I referred to at the start, is to help build a public mandate for more ambitious action on AMR. something we hope will prevent the types of negative impacts on patients that we're also fearful of on this panel, and that we obviously want to talk about in more detail today. Thank you very much indeed.
Thank you so much, Jeremy. Thank you so much for talking about the current state of the evidence, but also highlighting to us and certainly to the listeners on this call that we do need to do more in terms of evidence generation, but also surveillance in the cancer community on AMR and its impact on cancer outcomes. And it would be great to maybe return to that question a little later, hopefully during the Q&A. It is also very important now to look at the effects of AMR on cancer outcomes, not just in adults, but also in children. And we are delighted to have our next speaker, Dr. Lilian Sung. Dr. Lilian Sung is a professor and senior scientist at the Hospital for Sick Children in Toronto, Ontario, Canada. She's specialized and certified in the specialties of pediatrics, infectious diseases, hematology, and clinical investigation. She has a clinical research program focused on improving supportive care for children with cancer. Her methodological focus is on randomized and observational trials, meta-analysis, and patient-reported outcomes, and is the principal investigator on multiple operating grants from the National Institutes of Health, the Canadian Cancer Research Society Institute, and the Canadian Institutes of Health Research, Dr. Sun, thanks. It's lovely to have you. You have the floor.
Good morning. I'd like to start by thanking you for inviting me to participate in this very important event. So I was asked to talk about the clinical impact of AMR in pediatric cancer, and I wanted to start by setting the stage that most children with cancer will be cured today. And children diagnosed in Canada and the United States and Europe will, the vast majority will be long-term survivors, and currently 83% will survive for at least 5 years after cancer diagnosis. However, these impressive outcomes require intensive treatments, and these intensive treatments have lots of short-term and long-term consequences, including affecting your white counts or your neutrophil counts, which are your important defense against infections. The next slide, please. So to set the stage, I wanted to give you a scenario of a patient that I took care of. So I've altered some of the details so that this is de-identified, but to give you a sense of what the clinical impact of AMR is. So this is a girl who I've called Matilda. She's 9 years old and she has cancer. She was initially treated with a chemotherapy protocol, but she relapsed, so she's now getting more aggressive chemotherapy, and she's in hospital, but she's pretty happy. She's with her family, and she's on antibiotics because she has this ongoing fever. And I sign up for the weekend on a Friday, and I say to myself, I'm a little worried about her, but she looks well. So indeed, that evening, her heart rate starts to increase and the residents get called. And she starts to look progressively more unwell, and within 12 hours, her blood pressure drops. She starts to have trouble breathing. She gets taken to the intensive care unit, and she's intubated and put on a ventilator or a breathing machine. And 12 hours later, in spite of everything that the ICU doctors and nurses try to do, she dies. The blood culture that was taken at the start of this whole episode shows a gram-negative bacteria that was resistant to most antibiotics, including the ones that she was receiving at the time that she developed her problems. So next slide, please. So I wanted to talk about the importance of infections in pediatric cancer patients. Like you've heard in adults, infections are one of the most common causes of non-cancer related death during treatment or treatment-related mortality. And infections typically occur when the neutrophils or the white counts are low from chemotherapy. And the first sign that we have often of an infection is fever. And therefore, we have learned for a very long time that when fever occurs, when counts are low or during neutropenia, this is a really important problem, and we need to start antibiotics right away so that children don't die of infections, because these infections can be rapidly fatal. And for some of our diseases, such as acute myeloid leukemia, the risk of death is so high that we actually keep them in hospital the entire time, so that when their counts expectedly drop and they develop fever, we can treat them with antibiotics right away to try to prevent death. And what that means for a child who's newly diagnosed with acute myeloid leukemia, we will tell the families to expect to be in hospital for the next 4 to 6 months and essentially not be able to go home or go home for only 2 or 3 days in between chemotherapy cycles. Next slide, please. And so this chart shows you some of the data around the importance of infections in children with acute myeloid leukemia. So this is a study conducted by the Children's Cancer Group that studied 492 children. These children received 3 cycles of chemotherapy, and what you can see is somewhere between 50 to 69% of these children developed at least one bloodstream infection during each cycle. And remarkably, the risk of dying of infection was 11% during this treatment. So that means 1 in 10 children that received this chemotherapy died of an infection. So next slide, please. So I've talked about fever and neutropenia being a really important clinical condition for doctors and nurses that manage children with cancer. And thus we have required clinical practice guidelines that tell us what to do when children develop fever when their counts are low. So this is what I'm showing here is a guideline that was developed by an international group of experts in fever and neutropenia that help clinicians know how to manage this issue. And what these guidelines say is that if your center has a low rate of AMR or a low rate of resistance, you ought to be using 1 drug or monotherapy when children develop fever and neutropenia. So what happens when centers start to have increasing rates of resistance? It means that that center needs to start to use more powerful antibiotics to make sure that if that child has an infection, that infection is covered. And if their rates of resistance get high enough, sometimes they need to start 2 drugs when patients have fever and neutropenia. And if the resistance continues to get worse, maybe they need 3 drugs when patients develop fever and neutropenia. Fever and neutropenia is common. This means that these centers are requiring more and more antibiotics. What does this do to the patients? This means that patients experience increased toxicity because every drug you add is going to be associated with more toxicity. It means more costs for the centers. And what it also means is because we have to use stronger antibiotics and more antibiotics, that increases AMR. And so if you push next, please. And what that means is that means the center now has to use more powerful drugs and more antibiotics, which increases more AMR, and this becomes a vicious cycle. So next slide, please. So what does this mean in total? It means that we need to use more powerful antibiotics or more broad spectrum antibiotics when we have children with fever and neutropenia. It means that we need to increase the number of antibiotics required for patients with fever, neutropenia, or suspected infection. That increases toxicities and costs. That increases the risk that these children will have infections not susceptible to any antibiotic. And ultimately, what does this mean to parents and families? It means that children who might otherwise have been cured and grown up and had families, that these children may die because of AMR. So what do we need? We need strategies to manage AMR, both at the patient level and at the center level. But most importantly, I think we need to figure out a way to reduce AMR so that we can resolve this issue. Thank you.
Lillian, thank you so much for your powerful presentation. And I think, you know, as a clinician, you've really brought home the challenges that you would face and your colleagues face on a routine basis. And I think this really makes it very real. I'm just going to go to one question from Gary Cohen, because it is directed to you on this, on Matilda's infection. There's a question: did you determine the cause of Matilda's infection? Could you perhaps say something a little about that?
Yes, absolutely. So she had, as I recall, I believe she had a Klebsiella is what my recollection is, but I could be wrong about this. Could it be catheter related? You know, it might have been. It might have been catheter related. She was receiving pretty strong antibiotics. It could have been from her gut as well. But definitely it was a nosocomial infection, and definitely we would expect to see these infections for patients who've been hospitalized that long.
Thank you. Thank you very much again. And maybe we can discuss a little bit more around from a clinician's perspective. I know we have some clinicians on the call, but also from a patient, the importance of patient advocates in this area. I think that's a topic we could explore during the question and answer. It was raised also by Jeremy, as we do need to have more visibility of these issues in the patient population. So let's go now to our last speaker on the panel, Dr. John Kirkness, who is the head of Department for Cancer Research and Prevention at the Norwegian Cancer Society. He has wide experience in political advocacy, organizational development, and leadership. Dr. Kirkness is also a board member at the Gemini Center for Sepsis Research. Welcome.
Thank you, Sonali, and good afternoon, and thank you for the opportunity to speak at the London Global Cancer Week. We have now just heard prominent voices talk about AMR, a growing public health crisis that needs urgent attention. And the question, before I answer the question, how should the cancer community come together, I bring about policy change and why there is a need for relevant stakeholders to come together and collaborate towards finding feasible solution and its implementation. I will have, next slide, please. I will show you this. This is also what Dame Sally talked about. This is Helge Øvernes. He was 21 years old when he got leukemia. Over a 5-year period, he has undergone several chemotherapy treatments, stem cell transplantation, and a lung transplant to survive. Due to the stem cell transplant, he was isolated and depended on antibiotics. Without antibiotics, he would never have been able to receive the necessary treatment that saved his life. So it is just as true that antibiotics saved Helge's life as modern cancer treatment did. Helge is doing fine today. He is active in young cancer and supports us in many ways, also through his contribution in the fight against antibiotic resistance. So using cancer to give antibiotic resistant effect is a very effective using it as a face. Individuals can come forward with their stories and important, useful to showcase the challenge. So thanks to Helge. Next slide, please. Cancer organizations are big and strong, like trains, and it is our ethical duty to act and to take lead on this agenda. But cancer organizations need to seek new partners. Like many other cancer organizations, we fund research. Research collaboration is very important for organizing, such as to ask questions and to turn research in directions that can be useful for patients that we represent. Collaboration between cancer research, infection medicine leads to strong consortia that can influence on decision-making authorities. Here you can see a picture of our Prime Minister Erna Solberg gathering people from academia, private industry, civil sector to discuss this issue. This is just a couple of months ago. Next slide, please. Another example of partnership. In recent years, the Norwegian Cancer Society has collaborated with the Gemini Center for Sepsis Research to spread knowledge about antibiotic resistance and sepsis. Here at the right, you can see our Ministry of Health, Bent Høie, speak about sepsis, AMR, and cancer. We need to share knowledge and to make new strategies and innovative possibilities for infection treatments. Maybe not immediately into human medicine, but into veterinary medicine, agriculture, and aquaculture. If we share on such new activities and innovations, antibiotics can be reserved for our patients. So next slide, please. There's much text on this slide, but there are 3 important policy asks. The first one, data collection and survivalness. We should work together to increase the awareness of the risk of infection for cancer patients. That means it should be cancer registry should be established in all countries. Also about access to treatments. Cancer Society should also be among the first to take part in collaboration to ensure availability, affordability, and sustained access to quality assured medicine and diagnostics for existing essential medicines and diagnostics, but also the R&D, as I mentioned, for new medicines and so on. And that's also been mentioned from some of the other speakers. And the last point that you almost see at the right side is emphasis on the importance of AMR in parallel to cancer treatment. We must streamline AMR into national policy documents like cancer control plans and inspire other UICC members to reach out and do AMR advocacy work. So next slide, please. So what can we do and what have we done in the Norwegian Cancer Society? The Norwegian Cancer Society started an international campaign in 2017 to get other cancer society involved in the work of getting ordinary people to do their best to preserve effective antibiotics. To visualize this issue on the antibiotic resistance, we designed an exhibition. We wanted to explain the facts and myths about antibiotics and antibiotics resistance as visually as possible. How can awareness of antibiotica and the choice we make affect society, people's health in the year to come? The exhibition perfectly illustrated the effective antibiotica are already, and we called it Hanging by a Thread. And it was launched, marked for an opening that for the Norwegian Cancer Society Science Center in 2018. And in agreement with WHO, showed interest in the exhibition, and it has been a showcase in collaboration with them during the World Antibiotic Awareness Week from 2018 in Copenhagen, Denmark, and in Stockholm, the European House, and also in the Council of Europe in Brussels. And it was supposed to go to New York, Geneva, Moscow this year, but unfortunately due to COVID, that didn't happen. So we have to also rethink and think new solutions to get good awareness. Finally, what do we do then when the miracle medicine stops working? The answer is short and not sweet. We don't know. Together we must work to do what we can to prevent this from becoming a reality. If we are to succeed, we must, as the speaker had said earlier, we must work together both locally, nationally, and globally. As we have heard earlier today, bacterial infections that cannot be treated are growing a problem in all parts of the world. Bacteria know no borders and travel without tourists, food, water, animals, and birds, and so on. And we have seen it through COVID now. So back to the point that Dame Sally said, we have to use cancer to give the challenge of antibiotic resistance a face that's very effective. AMR is a nightmare, not only for the infection specialist or the oncologist, it's a threat for every human being. Think of all progress we have done when it comes to cancer treatment the last decades. We can't risk our patients' lives because lack of effective antibiotics. All sectors must intervene before it's too late. Therefore, we applaud the UICC, who represent a large patient group around the world, for joining forces. Thank you.
Thank you so much, John. Thank you very much for that, for your presentation and raising all those really important points. Now we have the time for the Q&A, and looking at the Q&A, I think our participants have been clearly blown away by all the information and are, I think, a little bit hesitant to ask questions, or perhaps they would like to ask questions in person. Please don't hesitate. What I'm going to do is just give you a moment, and please do indicate, and you can also talk directly if you'd like to. I will just look, you can just raise your hand and I will go through the screens to see if any of you would like to ask any questions. Otherwise, I will start a discussion with the group. Okay, well, maybe I'll just kick things off. You know,
No.
oh, you have a question? Great, please go ahead, Tim. Lovely.
Okay, no, it's just a quick one. I was thinking that, you know, we live in this time of COVID-19. We've gone through this pandemic. We're going through this pandemic. I wonder what lessons we can draw for AMR from this sort of period. I mean, I was thinking just to throw just a couple of quick ideas. I mean, for example, in the UK, there's been a great sort of discussion, a great interest amongst the public. And Mr. Knox was talking earlier about engaging the public as well as physicians. And there was an interest in death figures and people dying from these things. And with the COVID thing, there were certainly changes to the death figures in the UK as they started to build COVID into them. For AMR, at the moment, there doesn't seem to be, people won't put down completely on a death certificate that it's AMR. So you're not getting it's maybe sepsis, it's maybe something else. It's something that would add a clarity to numbers, start to perhaps engage the public a little bit more. Another perhaps thing from COVID has been IPC. I mean, when AMR really became a bit more on the sort of emerge on the scene, there was a lot of interest in IPC particularly. COVID has certainly taught us all about IPC, so maybe there's a kind of a positive thing that will grow for that aspect of the whole spectrum of AMR. And the other thing I think the final small point is really that one of the things here that the people are starting to think about is that what does the COVID pandemic mean for me specifically? And I think this is something coming back into AMR, which began very broadly, quite rightly, with the One Health concept involving the agriculture, involving vaccines, involving absolutely medical advances, the lot, everything. Now we've maybe answered these questions. What does that mean for us as the cancer community? What does that mean to us? Should we act on a more local level rather than the global level to start to redress some of the things that have been highlighted so far? I would be interested to know what the panel and everyone would think on that. What can we positively draw from what's going on now for cancer and AMR? So.
Thank you so much for that question, Tim. I'm going to direct that to Dame Sally Davies because Sally, you had raised the potential for us to really use this terrible crisis to be able to really build awareness on infection control. So why don't you go ahead and answer that, please?
Thank you. Thank you, Tim. You've raised some very important questions. And I think we start with the first, what do we get out of COVID? Well, we get out of it that infections, if they can't be effectively treated, can run riot across our countries and the globe and can kill many people as they go. And we also see that if you have cancer and you catch these infections, you may be more prone to catching it, but definitely they can be more serious. Leukemias in particular, even cured patients, their outcomes with COVID are horrible. But then I think we can learn more, and you picked up on many of these themes. Infection prevention and control, terribly important in everyday life, essential for preventing infections. That will reduce the need for antibiotics, which will save them for when we really need them. And how do we kind of get what has become new normal to continue? And we need to really work at that because we know people tire of doing these things and we're going to need our best behavioral scientists on it. But I do think it's very interesting that Australia in their winter had a very mild flu season. And I begin to wonder how much this is the infection prevention and control is beginning to reduce infections generally. And we may be able to use some of this to kind of highlight to the public that they are protecting themselves, their children, the cancer sufferers and their old grannies, which seems to matter. We were debating only yesterday in a Welcome-led discussion How do we take AMR forward to protect lives? And I think that we're going to have to use every method we can possibly find, but actually highlighting this as a silent pandemic that's happening and talking about health security, and this is part of it, I believe has to be an important way into the discussion and the money that will flow for health security. I've been describing COVID as the lobster dropped into boiling water and making a dreadful noise as it dies, while AMR is the lobster put in cold water that's slowly heating up. It's going to die, but it's not making a noise. It's the hidden pandemic, the slow pandemic, and we need to recognize this and make sure that action on health security, whether it's surveillance, whether it's the global cooperation to bring new drugs and vaccines to market or stronger supply chains, that all of that is utilized and strengthened for AMR and to mitigate it going forwards. Thank you.
Thank you very much, Dame Sally. I believe also that Jeremy, you have a comment in response to Tim's questions. Please go ahead.
Yeah, I think Tim raised some really good points. So I think on the question of the data and the numbers on the mortality figures from AMR, I think that's a really kind of good one. And at Welcome, certainly we spend a lot of time and effort trying to look at how we can improve surveillance of drug resistance and try and get better figures. In a previous life, I worked with Jim O'Neill on his review of AMR, and one of the striking things when we started that was there was just no good global estimate of what the burden looks like, and that was really a barrier to making progress. So I think having that data, I think, is really important at a government level. I think having granular data, including things like death certification data on AMR, is tremendously important to help governments grip this and to get them to understand it. But I think that's not quite so important in our experience for the public engagement. I think taking cancer as the kind of the obvious example again, one where the public are emphatically kind of engaged on the topic. I think most people on the street would not be able to tell you the UK's death toll from cancer, but they could probably very easily seize upon the figure that 1 in 2 or 1 in 3 people will contract cancer in their lifetime. That's a much more accessible figure because it relates much more to the kind of the personal and the family experience. And I think that's what we have been finding at Welcome in our work, is that actually that's what really gets the public involved more so than the big numbers. It's, I think, very striking from COVID. Jeremy Farrow, the Welcome director, was making this point just yesterday, that the public have very quickly become inured to the big number that we see every day on the news of how many people get COVID each day, how many people are dying each day. You can't really compute those numbers. So getting it down to the granular kind of individual level, I think, is the really important thing for driving that public engagement and creating that public mandate for action.
Thank you so much, Jeremy. I think that really segues very nicely into a question I also had, and I see that one of our participants, Barbara Sutter, has as well, and that's really on patient involvement. And how do we do that? I think, you know, one of the cancer is a visible disease because of, well, largely because of the work that our patients do in bringing it to the public attention. Breast cancer, prostate cancer, through movements like Movember. We are in November, so, you know, really recognizing the impact that male cancers have on the male population. So what can we do really to raise the patient voice? And you know, Barbara asks here, patients, particularly with multi-drug resistance bacterial infections, you know, how do we have patients demand health system action? What can we do in terms of practical steps? I mean, we'd be looking at this very much as the start of galvanizing our patient community. But I'll ask you again, Jeremy, and then move to our other speakers to make some comments on that.
So I think the way we've been looking at this in Welcome is that I think we know we want to mobilize the patient community, but I think we still suffer from the fact that people don't see AMR as the problem. Even where they may lose someone that's close to them to AMR, they may think that it was cancer or old age or something else that was the cause. And I think we don't want to try and kind of create a competing campaign and trying to kind of compete for oxygen with and trying to kind of make it a separate thing in its own right. I think really we see the greatest mileage in actually making the type of case that I talked about. So talking to big kind of already well-established, well-motivated patient communities, be they the cancer community, the cystic fibrosis community, the diabetes community, who all have kind of really do have skin in the game when it comes to tackling AMR, but already have the kind of already established kind of patient communities. I think it's far more powerful to kind of go through those groups and talk to those established communities about why AMR matters to them and get them to kind of make it a core part of their narrative, a core part of what they ask for, campaign for. That I think is the more efficient way of doing it, and really kind of is the win-win here, rather than trying to kind of create a separate sort of separate kind of standalone, discrete AMR patient lobby.
Thank you very much. I'm also going to look at Abdul Ghaffar. If, for example, in India, can you tell us about your efforts? So how have you been able to galvanize patients around this topic?
We really need to involve patients, especially cancer patients. And cancer patients should be on the forefront of AMR advocacy. And that will make a big difference. And when cancer patients talk about cancer, politicians and policymakers listen. When cancer patients talk about AMR and cancer, they will listen. So far, we haven't involved the cancer community in the tackling AMR efforts. It has been a collective, oncologists are involved, but cancer patients haven't come forward in the tackling AMR efforts. This is probably one important thing that we should be looking in future in all countries.
Thank you very much. Isn't it an issue, though, particularly in LMIC countries, that we don't have such great evidence? I mean, we've been talking to some of our oncologists working in different settings, in some countries in Africa and in Asia, saying that we know this is a problem because our patients we're seeing resistant infections in our patients, but we just don't have the surveillance data. Do you think that's an issue that we need to tackle policy-wise? Is that one of our key areas for action, in your view?
We do have more than enough evidence to act. The lack of data should never be an impediment for tackling AMR efforts. Just not in oncology. Whenever we discuss about AMR, we always come across this question: we don't have enough data to act. Of course, we need data, but we can't wait for additional data to initiate efforts. We have more than enough data in oncology setting and non-oncology setting to do whatever necessary to mobilize the political momentum to tackle AMR.
Thank you very much, Abdul, for that point. And just throwing that across to John Kirkness, because you also mentioned in your slides the importance of surveillance. Can you talk a little bit to us, in your context, certainly in Norway and in Europe, the importance of data, not necessarily just for advocacy purposes, but how you anticipate using data effectively?
Yes, thank you, Sonali. About data, we will use it in our awareness work, because you can think that we have enough with prevention and control of cancer, but I think it's so important to have this AMR work, because it needs all hands on deck. And I think that we need to have this evidence, and we have to state what kind of death issue and so on. And so I think the cancer registries should be very important. There's also why we work closely with the Center for Sepsis, the research for sepsis and so on. But I also like to mention one more thing. I think that's what Ghaffar said. The Norwegian Cancer Society does this to give the case a face, that we use cancer as an example. That's because, as Jeremy said, most people are concerned about cancer and therefore understand the seriousness. So we think that we can speak on behalf of anyone who have become ill or for the infections. We would like all types of patient organizations to engage in a similar way and take on AMR. Our strength is that we can take the users and patient's voice and the view, and regardless of diagnosis. So this is how we stay relevant, and why we are often asked to take a seat at this table and so on, because when this challenge is being discussed and when new strategies and action plans are being written, the patient's voice has to be part of the work, as I said, with a cancer plan and so on. But in this, as you said, data and collection of this, I think that's crucial because we need the evidence. Thank you.
Thank you. Thank you. And I think, you know, absolutely on the, so straddling those things is certainly not to wait until you have all the evidence to act, but to continue with the evidence. And so that informs the policy. In the cancer community, we talk about cancer surveillance. So cancer surveillance is essential for us to be able to plan our national cancer control response. So, and it's an ongoing thing, right? So I think this linking with the AMR surveillance helps us to anticipate what's happening, and but also to look at, well, where the interventions work. So that's a point well taken. Lillian, I would also like to ask you then for the patient advocacy question, and also there's a clinical question I'd like to put to you from one of the participants. Go ahead.
Great, thank you. So I wanted to talk about something really tangible that we as a community can do to improve the AMR issue. And the first is following clinical practice guidelines. There are data available that tell us what we should do and the roles of multiple antibiotics to treat specific conditions. There are clinical practice guidelines that say, use monotherapy, use one drug in this situation. And what we know is that guideline inconsistent care, so when clinicians don't follow guidelines in the setting of fever neutropenia, we know that patient outcomes are worse. They do worse, they die more. There's lots of impetus to improve concordance with clinical practice guidelines. So first, I think as a community, that could be a very simple focus, which is how do we highlight what are the guidelines that are available regarding antimicrobial therapy, and what steps do we do to improve guideline consistent care? Now, what can families do vis-a-vis guidelines? So an initiative that we have started is we have clinical practice guidelines that are written for clinicians, nurses, pharmacists. What we think ought to happen is that families should be aware of what are the recommendations available that incorporate the best evidence that help clinicians know what to do. We think families should be aware of what's out there. So we have started to take guideline summaries, including for fever neutropenia and antibacterial prophylaxis and antifungal prophylaxis, and convert those into summaries that are appropriate for parents and siblings so that they can understand them, they understand what they mean. And what we hope that means is that they can start to advocate and say, wait a second, why am I getting this? This doesn't make any sense, right? And so we think that that's really important for families to be partners with us in improving the quality of care that we provide. So that's really what I wanted to comment around an important step I think we could do to try to improve AMR. The second comment I wanted to make is, how do we obtain data around AMR and the impact of AMR and outcomes? I think we can do it, and I think we could actually do it in a cost-efficient way. So I belong to a group called the Umbrella Network, and the Umbrella Network are centers across Europe and North America and Australia that treat children with cancer that have worked together to say, we want to try to improve infection outcomes. And one of the projects that we did was actually focused on AMR. So we have data of 1,200 episodes of bacteremia where we can show that AMR is associated with ICU, it's associated with mortality. And that's in peer review publication now. That project was done with $0. So we can do these projects actually. We can do high quality work. What we need is we need to work it together as a community. We have to decide that this is an important problem, and we have to just make it happen. So I think that there are some things we can do that are relatively low-lying fruit that can be important and impactful. I think that the big win is going to be ultimately improved ways to deal with AMR, but that these are incremental steps that we can do that are fairly simple, that don't require a lot of resources.
Thank you so much, Lillian. Thank you so much for your point about the data, because that's it, isn't it? You tend to worry that it's going to cost a lot of money to be able to do a big observational study, and is it possible to, you know, get a registry to start to collect on AMR, and there could be pushback. I certainly would like to do follow-up discussions with you about that, because we are, as you know, starting to look at how we can really better link surveillance, AMR surveillance, with cancer outcome measures, etc. So I just want to also ask you, there's a question from Josephine Pradhan. It's a clinical question. Can you tell me how many isolates should be studied when taking samples? Is it just one, or how many for healthy individuals? Lillian, could you comment on that question?
Sure, I can certainly comment. I can't talk about healthy patients because I don't treat healthy patients. I only treat children with cancer. But I can certainly talk to you about our standards for children with fever and neutropenia. So most of our children, at least in high-income countries, have a central line. That's going to be different than in low and middle-income countries. But in high-income countries, when you have a central line, the line is very frequently maybe the site of the bloodstream infection. Certainly, it is standard for all children with a central line to have a blood culture drawn from each lumen or each line of your central venous catheter. So some of the catheters only have one lumen, some may have 2 or 3 lumens, and that allows you to give 2 drugs at the same time, for example. So I would say, as a very minimum, everybody would say you must draw a culture from each lumen, because a lumen could be contaminated and the other one might not be. I think, so that's the standard, at least one. There are lots of debates about whether or not you need to draw a culture from a peripheral blood culture at the same time you do a central culture. I would say that the data support that there may be some advantages for doing a peripheral culture, but the ways and the risks and benefits are fairly closely balanced. So some centers may choose to do it, some centers might not. So minimum 1, some centers may choose to do 2.
Thank you very much. Thanks very much, Lillian. If you have any other questions, clinical or otherwise, please do send them through the chat. I'm actually now going to call on one of our participants, Patrick. Patrick, you have a few very interesting questions. So I'm actually, rather than reading them, I'm going to ask you to say them out loud. Over to you.
Hi, thanks very much, Sonali. Sorry to, well, recently joined NIHR on the global health portfolio side, and it's just really interesting to see both how we're working across with funders, including Welcome and many others, and also direct programming and direct funding calls, moving towards funding LMIC-led consortia and projects. But I think there's been a bit of a silo between sort of NCDs, including cancers, and the kind of global health security stuff, AMR and now COVID, which is actually, I mean, that's true even with the Department of Health, and obviously Dame Sally, set up NIHR and has been involved in that, but there's still slight disconnect. And so this is a really interesting, I really wanted to attend this because it is actually, cancer people talking to AMR people, and just to sort of get a sense of how we as funders can kind of work together in a bit of a more integrated way across those programs, but how to be responsive, but also to have the sort of the long-term trust and relationship building as well. Sorry, it's a really impossible question, but just wondered if anyone had any insight onto that. Thanks.
Would anybody like to answer that question? Jeremy, do you have a response on that? And also John?
Yeah, it is a very tough question, and certainly from Welcome's perspective, I mean, I think yes, we kind of focus very much on AMR, and I think we kind of focus mainly on trying to integrate AMR with wider efforts on infectious diseases, and kind of tying up with kind of overlapping areas around, like you say, global health security. I think we probably haven't got our head around kind of exactly what the overlap looks like with the NCDs, to be honest. I think that's still a bit of a kind of a challenging area, but I think there's still enough to be done in terms of actually building out a kind of a properly prioritized AMR research landscape and how to integrate that with the post-COVID global health security, pandemic preparedness agendas. So I think that's a kind of challenge enough in itself. And I think when it comes to, on the LMIC's point, I think what we're increasingly trying to do at Welcome is trying to work out how we can operate both at a global level, but also how can we do more as a London-based funder that has global reach but doesn't have a global presence. How can we try and support work which is closer to communities and LMICs and really much kind of more clearly guided by the needs and priorities in LMICs. And that's not a straightforward thing for us. It's a bit of a kind of change from our usual model, particularly of being a responsive funder. But I think it's absolutely kind of intrinsically important to mounting an effective response to AMR. I think going back to one of the previous questions, I think one of the real challenges that comes with the data or the gaps in the data is really that prioritizing the global AMR response is very, very challenging. We do have enough evidence to be able to justify why we need a response, but then particularly in LMICs, when it comes to actually saying, well, what comes first, that is much more challenging. Welcome has published a landscape analysis this week, which has tried to look at what the global AMR landscape looks like and trying to kind of pick out what the global research priorities, what really the focus of effort should be over the next kind of 5 years or so, to try and kind of begin to make headway with that. But it's a really kind of tough nut to crack. Sorry, that probably doesn't entirely answer your question, Patrick, but you did say it was an impossible question. So.
Thank you, Jeremy. I just want to hand over to John, because the Norwegian Cancer Society has been working in this space for quite some time, and I'm very curious also in response to Patrick's questions, how well have you been able to talk to other communities, NCD communities, the other infectious disease communities? What have you done in that respect in Norway and in the Nordic countries in particular?
It started also in 2017 where we had these workshops, and we have the Ministry of Health, and we have all this gathering to put it on the agenda. And now it has been turning around to again Patrick's question, what should we use our funds to? Should we have more collaboration with other partners concerning research and so on? But we don't have a simple answer on that one, because it's but we are working, and also at national Ministry of Defense, now the health level, and the Norwegian Cancer and Research Fund, to see like antibiotic is one of the topics that we want to do, seek new solutions, but we don't have a clear answer yet, but it's in working progress on that one. Thank you.
Thank you very much for that. Now I just want to then shift gear from patients to health providers, and Lillian, I think you touched a little bit among this, in your talk also about responsible practices in hospitals, and how big a problem is it in hospitals of irresponsible or use or irrational use of antimicrobials, particularly antibiotics, and what has been your experience? Of course, you work with colleagues, you work predominantly on pediatric malignancies, but in your career, what has been your experience, and is the situation difficult? And what is your experience, and what can we do to improve it if it is so? Thank you.
Thanks. So this is a great question. We actually, the first answer to the question of how are our clinicians doing in terms of antibiotic prescribing practices, and are they following guidelines? We're just actually starting to get data on that now. We have a NIH-sponsored children's oncology group study in which we went into, I think, 35 or so sites in the United States to look at their charts to see were clinicians following clinical practice guidelines related to giving too many antibiotics. We actually don't have those results yet, but we've started to get that data. But I can tell you, as someone who did those reviews, there are a lot of kids out there getting way too many antibiotics. And I think from the front line, what the perspective is well, you just better be safe than sorry. Let's just give everything, because you don't see the immediate downside of what happens when you give too many antibiotics. So I think that is a lot of education around why is giving too many antibiotics bad. And even if you don't see the consequences immediately, your center ultimately will pay the price with increasing AMR. So that's my first initial response, which is I think we're just starting to understand now the magnitude of the problem. We know it is a problem, we just don't have precise estimates. The second thing I wanted to talk a little bit about is another potential way we can start to measure practices and AMR in a relatively cost-efficient way. So I don't know how much discussion you guys have had as a group on electronic medical records and being able to harness EMRs. I've been at Stanford for 6 months and looking at being able to do analyses using EMRs. And what I can tell you is there's more and more work being done to try to be able to look at what drugs are prescribed globally and using a common language. And there is a common language that appears to be evolving internationally around how you describe events in the medical records. And that can include both resistant organisms and antibiotic prescribing practices. What I can tell you at Stanford is people have not really started to look at this issue, but clearly the data exists, and it would be something that would be worth probably investing a little consideration in, is that if you could start to measure both resistance and antibiotic prescribing practices, you would then have access to data from a huge number of centers in China, in India, in the United States, in the UK, in Europe, everywhere around the world is starting to use this kind of system. Anyways, that was probably more information than you wanted.
No, not at all. That actually was absolutely right. And yesterday, UICC had another interactive dialogue on antimicrobial resistance. This was in collaboration with GARD-P. And this was, looking at the drugs don't work, what do we do? And we had a presentation from the Oman Ministry of Health, and it was from the Infectious Disease Department. And actually Oman has taken quite a strong approach to the use of antimicrobials in the country, and have implemented guidelines, but also track their usage in centers across the country, in public health centers. So they're able to see, and they're able to see at a granular level what is being prescribed, whether that's an overprescription, and looking at but also looking at the data of the from the patient electronic records and the pharmacology database of whether that was justified, and have a center looking at that. And that's actually, I think, what you say is feasible, and certainly we know of Oman, and there could be other countries doing that. And I think it's what we would like to do is maybe to start to collect those case studies to show that you can have a strong policy response, which shouldn't be seen as a kind of a punitive response, because that needs to go in hand with the awareness side of things, as you say, to medical professionals, sort of just saying, well, we better be on the safe side, but really saying that no, at a policy for our country, at a collective level, it's beyond the individual. We need to safeguard an individual's health by having this collective action. So I don't think it's too much. I think it is something that we could look at. Abdul, would you like to comment on that? Any sort of the policy level approaches that countries could take? What's in the Chennai Declaration, for example?
The Chennai Declaration is an initiative by medical societies in India with the help of many governmental and non-governmental organizations. The main purpose of Chennai Declaration was to mobilize the political momentum to implement national antibiotic policy of the country. And it's predominantly a socio-political initiative. It's not an academic initiative. And we succeeded to an extent. We created a lot of, momentum in the country. And similarly, most of the countries, there were similar initiatives, and we succeeded. But unfortunately, after 2015, 2016, there has been a slowing down in the global momentum on AMR. And it's unfortunate, but this is a time we need to reinitiate, and probably we redo a lot of things what we did earlier, and then take it forward. And as you all know, AMR is much more than antibiotic usage. You know, we in hospital rationalization of antibiotic it's one of the smaller components of the bigger picture of AMR. If you ask me, really, I lost interest in, you know, rationalizing hospital antibiotics. Many Indian centers, you know, do good job in rationalizing antibiotics, but of course, not all Indian centers. The issue is so complex in India. But much more important is improving sanitation, improving over-the-counter sale of antibiotics, the collective work of medical community, the politicians, the policy makers. It's too complex, and at the same time, we need to act on all components. So if you ask me who is the most important stakeholder in AMR, it's not doctors, it's not medical community, it's the public. It's the public. Involve the public, we will succeed. Keep away the public, we will fail. We learned our lesson from the work in the last 10 years.
Right. Thank you very much. And I'm just going to, in the last couple of minutes, I'm just going to not say more of a provocative question, but the bigger issue is not that, you know, the implications of AMR are, it seems that we have to deal with it only in health, but it's not really just health, is it? It's the agricultural sector, it's the animal health sector, it's this bigger, what you call this One Health approach. So, I mean, are we kind of hitting our heads against the wall just by focusing only within health? Can any of you, as a last comment, I mean, do any of you have experience in working with other health sectors? I know that might be beyond the cancer community, but what could we do as the cancer community to sort of, you know, spearhead some of those discussions? Jeremy, I'll go back to you on that, because I'm sure Welcome has been sort of banging on about that with other people, with other departments in the ministries.
Yes, it's a really good question, and I think it's one of the, I hesitate to say unique, but certainly a confounding factor in the AMR response is as Abdul says, it needs to engage with the animal side of usage, the environmental side of usage, as well as the human side. I think we definitely try and avoid getting into the question of well, how to apportion most blame. It varies by country, but I think the single universal truth is we're using more than we should, whether that's in humans or in animals, pretty much anywhere in the world. I think the way that I would see it is we are seeing increasing cooperation between the human health organizations around the world and animal health organizations. At a country level, it's more mixed, but we are increasingly seeing that the national action plans on AMR do have participation from agricultural ministries as well as human health, the human health side. I think when it comes to the question of the cancer community, I think all, sorry to sound like a stuck record, but it still kind of boils down to helping build that public mandate.
Okay.
Because I think if people really start to seize upon the human impact, the impact to them of AMR, and really start to kind of be very clear that they expect governments to start taking AMR as a problem seriously, that sort of kind of public mandate gives political coverage for what often is kind of quite difficult decisions, and frankly taking on kind of tricky vested interests when it comes to the agricultural side, and saying, okay, well, we need to be stricter on agricultural usage. We need to do things that maybe might put pressure on farmers. It may put upward pressure on food prices, or be perceived to. Those sorts of things, the kind of the things that politicians get very naturally very nervous about, they need to have a political cover, and there's nothing better realistically than providing that sort of political cover than a really vocal, kind of strongly mobilized patient community, I think.
Thank you so much. Well, I think that ends on the point that all of you have been making, the importance of the patient community. And I think that is a really good follow-up point for us on the call, that the cancer community participants on the call, for us to really look at how we can do that. And certainly UICC will be launching our own campaign on cancer and AMR, working with many of you into next year, and looking at really increasing the patient voice in this area, particularly the patient voice from the cancer community. So thank you so much. Thank you for the really great policy level recommendations. We've heard the importance of infection prevention and control. We've talked about the education of patients, which is key, but also family members, not to keep them outside the loop on these discussions, the awareness and training of medical colleagues. raising this issue in the eyes of the public, but really using the cancer community voice as a conduit to do so. We've heard about the importance of surveillance, but really using surveillance effectively, not to hold up action, but to inform action. One area that we didn't get to talk about so much, a little bit, was really about the drug development and the private sector. Clearly, the private sector have a huge role to play here as partners in this effort, and we know that efforts are ongoing there, so that's to be really encouraged. So I think that's we've now reached time. This has been really a wonderful session. Thank you so much for your expert insight into this important topic. Thank you for the time. Wish you all a lovely afternoon and a lovely day to all of you. Thank you so much.
Thank you.
Thank you.
Bye-bye.